chest or in the lung or mediastinum, then physician will go for next step, and that is basically depending on the size of the mass, location, and so on. Those cases usually refer to pulmonary doctor and thoracic surgeon to complete the workup. But initial workup, you need to know the nature of this mass. Usually those malignant lesion, the radiologist will tell you this looks malignant based on the size, the irregularity of the surface, the content of it, the pattern of spread in that area. So the radiologist will tell you, yes, this mass most likely to be cancer. Also, could see other mass, oh, that is unlikely to be cancer, but we need to rule it out. We need to rule it out or observe it. So in the first case, when it's highly suspicious of cancer, patient seen by the pulmonary doctor or the thoracic surgeon or together, then they go for next step, which is basically patient will undergo battery of tests, including bronchoscopy. The pulmonary doctor like to look on the airway, the trachea, the main bronchus, and so on. Again, I wanted you to know if the lesion is very peripheral, sometimes bronchoscopy is not helpful. Bronchoscopy is more helpful when the lesion is more central, because the pulmonary doctor will be able to visualize those lesions as he enters those large branches from the main stem bronchus. And once the pulmonary doctor identify any endobronchial lesion, they biopsy it and they do washing around it. Those biopsy specimen and washings are sent to pathology. Pathology look at them and confirm the diagnosis of cancer. Sometimes the cancer is not inside the lumen, is not inside the bronchus. Sometimes it is outside. We call it extraluminal. In those cases, those patients will undergo CAT scan guided needle biopsy or transthoracic needle biopsy. These under CAT scan image, needle is directed, they go through the chest wall and take sample of that mass and sent to pathology, and pathology give you the diagnosis. So once diagnosis made, and diagnosis made only when you do biopsy, taking sample of the mass and look it under the microscope, then say yes, this is cancer, or say yes, this is not cancer. When it is not cancer, depending on the way they take the biopsy, many times we call it false negative, meaning they take sample, they look at it, and it is benign tissue. The yield sometimes is not 100%, and we call it false negative. And sometimes those cases, either if the lump is suspicious and there is question about the needle or difficult to biopsy it, sometimes those patients undergo excision of this mass. Again, that will be decided by the thoracic surgeon and the pulmonary doctor. Once you have the diagnosis of lung cancer, then you need to know whether such cancer spread or not. And there is certain battery of tests need to be done. Nowadays we use PET scan is an advanced way of looking at the whole body, and you look for if any other spots suspicious for cancer, indicate spread of cancer, and so on. If patient have neurological symptoms, we do MRI of the brain just to make sure the cancer did not go to the brain, and so on. So you direct or we direct investigation depending on patient's symptoms. To you, I wanted to outline. We classify lung cancer into two components: small cell lung cancer and non-small cell lung cancer. Small cell lung cancer is not a surgical disease. It is treated with chemotherapy primarily, and the radiation is added together with chemotherapy for some benefits, which I will explain to you in a few minutes. So, small cell lung cancer primarily treated with chemotherapy. Then you have non-small cell lung cancer, and such cancer treated primarily with surgery if it is early or resectable. Small cell lung cancer represent about 20% of whole lung cancer. Non-small cell lung cancer represent about 80% of lung cancer. I wanted also you to know that unfortunately, for non-small cell lung cancer and small cell lung cancer, the majority of cases are presented little bit advanced. For non-small cell lung cancer, about 60% or so present with advanced stages, stage 3 and 4. Only a third or so will present with early stage disease. For small cell lung cancer, about 20% present with early disease and 80% advanced disease. I will not talk for small cell lung cancer now, not to confuse you. I'm going to focus for non-small cell lung cancer, which is the surgical disease. Then after we finish talking about non-small cell lung cancer, we will be talking about small cell lung cancer. So, non-small cell lung cancer, about 2/3 present with little bit advanced disease. And those advanced disease, the surgery is not the primary treatment, and many times is not the treatment, simply because either this tumor is so advanced, and if you resect it or not, you still are not going to remove the disease completely. So it is essentially non-surgical disease because it is little bit advanced. Those patients treated with upfront chemo and radiation therapy. Chemotherapy and radiation therapy together are treated, then they are assessed later on whether they could be surgically resected or just chemoradiation is a good treatment only and do not need any further treatment. The prognosis depending on the stage. For early stages, when the tumor is small, completely resected, the survival is reasonably well. We're talking about 60–70% chance of 5-year survival or cure on those patients with non-small cell lung cancer when the tumor is small, completely resected. For little bit advanced disease, when the tumor present in the hilar lymph node, the hilum of the lung, we have the hilar lymph node and the mediastinal lymph node. Mediastinal lymph nodes, those are the lymph nodes around the trachea and the main stem bronchus. The hilum is at the end, and the hilum of the lung, we call it hilar lymph node. If cancer spread to the hilar lymph node only, the prognosis is still much better than if the cancer spread to the mediastinal lymph nodes. For those patients, when they have just 1 or 2 or small number of hilar lymph node and they are surgically resectable, your 5-year survival could be up to 40%. When the tumor spread to the mediastinum, some studies tell you 20%, some studies tell you 5%, and so on. Why there are difference in reporting? Simply because there are other factors influence outcome. Those factors are performance status. Those with good performance status, younger